Assalamu alaikum warahmatullah. So today we'll try to cover asthma as it's a very important topic in pediatric. So first you have to define what's asthma actually. Asthma is a chronic inflammatory disorder. Because of this inflammation, we will be having swelling, because of the inflammation swelling, and this swelling because of the edema, and this edema will cause obstruction. But this is usually happen in other respiratory disease, but especially in asthma we have something called hyperresponsiveness, where like the our bronchial wall act like over dramatic, something like this. So it's have hyper responsiveness, not like usual airway. And then because of all this story, we're gonna have recurrent episodes. Asthma is very characteristic of recurrent episodes. If someone presented with similar symptoms like asthma but with no recurrent episodes, never think of asthma. Shortness of breath, wheeze, chest tightness, and coughing, these are the clinical finding, especially at night or early in the morning, allergic rhinitis. It's always people knows who has allergic rhinitis. Sometimes they just woke up, keep sneezing for a while until it stops, or sometimes it's at night before they sleep. So okay, moving on. So you have to ask about this, especially you can ask the mother, is it like, do you notice it's very worse at night? Is it worse before, when he woke up in the morning before school? Something like this. Due to airflow obstruction, but it's often reversible. Like one of the investigation for asthma is response to treatment. So it's reversible spontaneously or with treatment. Okay. This is some notes I want you to notice. Uh, FEV1 is reversible about 12%. So if you have a kid who has like this episode of shortness of breath, and you measure his FEV1, and then you measure it again post bronchodilators, and there's like 12%, the patient become better. It's very characteristic of asthma. Any history of pneumothorax, intubation, always you have to classify it as severe asthma. We'll move to classification of severe asthma, but just put it in your mind. Okay, then pattern of wheezing. Wait, because before we go to pattern of wheezing, how does actually the pathophysio of asthma? Okay, first we have to start with the genetic predisposition. Of course, not anyone. You always have this family, always like this family related. They all of them have asthma or allergic rhinitis. So genetic is very important. Atopy, someone with allergic rhinitis, eczema, you know him of full eczema, allergic rhinitis, atopy, these things. And environmental triggers, of course, someone who's always surrounded with smoke, upper respiratory tract infection, allergen, house, dust, pollens, like he's always around the factory, smoking, cold air, exercise, whatever. So all these will lead to bronchial inflammation. Inflammation will lead to edema, and this edema is characterized by excessive mucus production, infiltrative with cells, like it's not just mucus, which cell, eosinophilic cell, mast cell, and neutrophil lymphocyte. And then moving on, bronchial hyperresponsiveness, as we said, dramatic, act like dramatically, hyperresponsiveness, exaggerated twitchiness to inhaled stimuli, like it act very, very dramatic to that inhaled stimuli. Okay, and then airway narrowing, because of course you have, this is the airway, if it's covered by edema here, okay, and another edema here, because of bronchial hyperresponsiveness. Look at the airway you have, it's very small like this. So this caused airway narrowing, reversible airflow obstruction, peak flow variability. Of course, the symptoms show the wheezing. We want to talk more about wheezing, especially we have two types of pattern of wheezing actually: transient early wheezing, and this one is not actually characterized of asthma. The one that has asthma is persistent wheezing and recurrent wheezing, not any kid who present with wheeze episodes, you say he has asthma. There's so many to know. Is it persistent and recurrent, or is it transient only wheezing? Transient, it's usually preschool, like younger than than 5 year old, and associated with narrow obstructed airway triggered by virus causes. It's always upper respiratory tract infection. Okay, common cold, and there are risk factors like prematurity if the mom smokes, family history of asthma, but it always resolved with 5 year old. That's why we never say to a patient who presented with wheezing episodes that he has asthma until 5 year old, because it might completely resolve. Moving on to persistent and recurrent, might happen to pre or after or school age. Sorry, wheeze associate with evidence of allergy, like a specific wheeze, like he always produced that wheezing sound to that allergen. So there's evidence of the allergy to inhaled IgE allergen, whether it's pollen, smoke, like sometimes special things, and it's persistent, not like transient early wheezing. Some might happen once a year or very like little, not mentioned, not noticeable. And because of this, it has reduced the lung function, and we call it atopic asthma. So what do you ask in history? Of course, we said before, you have to ask about the symptoms. Is it worse at night, early in the morning? Whistling sound, some patient doesn't know what wheeze is, so you ask the mother, does your kid produce like whoo? I don't know how to whistle, but whistling sound. Is there any specific trigger, like after raining? Does this happen every time after rain because of the cold air? Does it happen every time because of AC? Sometimes might cause, if it's cold. Does it happen every time he goes outside to put like dust when you clean? I don't know, something to the carpet. Also, you have to ask any carpet at home, because yes. And interval symptoms. Do you know what's interval symptoms? It's like he has episode of exacerbation, acute exacerbation of bronchial asthma. Okay, like this happens. Let's say 3 months ago. Okay, and now he had another acute exacerbation of bronchial asthma. But what's in this period? What happened in this period? This is what we call interval symptoms. This in this area. So how is it interval symptoms? Is it severe? Is it recurrent? Did it disappear like this? And is there any personal history of atopic disease, or even family history, like, and positive response to bronchodilators? This is always a very key, something important to mention. Okay, now you're suspecting asthma. Okay, or let's say you have a patient who already diagnosed with asthma and he presented with acute exacerbation. You have to classify the pattern. How do we classify asthma? There is two main things to say in asthma: either intermittent, okay, or persistent. But persistent asthma itself, we have three types for persistent asthma: mild, moderate, and severe. Okay, mild, moderate, and severe. So again, intermittent or persistent, mild, moderate, or severe. And okay, so you start asking, how do you actually classify? It depends on the symptoms. How the symptoms is it less than 2 weeks, 2 days a week, less than 2 times a week? So this is intermittent. If it's mild, up to 2 times and more. Moderate, it's daily. If it's daily, this is moderate. Severe, through the day. This moderate is like happen daily, but might be once time a day, 2 times a day, and then it goes away. But severe, it persistent through the day. It might happen with him so many times. Uh, Sorry. Night waking. Does he wake up during the night from this asthma? If no, this is intermittent. Might wake up 1 to 2 times and then go back 3 to 4, and then more than one times a week, if he has like woke up every week he has to wake up from asthma, okay, this is severe, but never intermittent, but during 1 to 2 times a month, okay, 3 to 4 moderate. And you have to continue reading the table. um what's something important to say? Yes, just read this table. Okay, so what are the question? You want to cover this table, right? To classify the patient's asthma later. So you ask this question: how frequent is your symptoms? Of course. So how frequent is your symptoms? Do you wake up at night? How many times? What trigger it? Is there any allergen, a specific thing or not? Is it sport or general activity are affected? Is sport like, is it asthma induced asthma, exercise induced asthma? And how often your sleep disturbed? What is this sound? Okay. And then how severe interval symptoms, we just explained what's interval symptoms, and how much school missed of asthma. You can ask the mom, did he miss school before because of asthma? Was he intubated before? Did he had any complication before? Like this. Okay, during physical exam, what are we suspecting to see? Physical exam, of course, wheezing. You can see prolonged expiration, like the patient, you see he's inspiring and exhaling. Inhale, and when he exhale, it's very prolonged because he has obstructed air inside and he cannot get it out. So prolonged expiratory might be hyperinflated and Harrison sulcus. This is Harrison sulcus. Look at it. It's like depression at the base of the thorax. It's all, you cannot always see you can't see it just with simple asthma, just with chronic obstructive pulmonary disease and severe asthma. You can see it like in severe asthma. And during the physical exam also, look if the patient has any eczema, any allergic rhinitis. Does he has runny nose, clubbing, sputum bag? If he has one, look at it. Maybe he has his asthma triggered by pneumonia or something. And growth failure, is he developmentally okay? This is special about pediatric patients. And okay, your investigation, now you're suspecting asthma very much and you want to investigate. In pediatric, you cannot do spirometry if they're like young, but usually diagnose it through history and physical exam. You can do skin prick test for allergen. This is useful, especially if in children. And chest x-ray to rule out other causes if you're suspecting something else. And of course, PEFR. Um, Okay, this table you have to read, you must read, assess after you assess the severity. We have mentioned here the intermittent and persistent. Here, it's more to the persistent type, moderate, severe, and life-threatening. We added this one. So, you can go through the management later, but it's very simple. Just read Sabalaba and inhale ICS, inhale corticosteroids. And this simplify very much, but I want you to concentrate more on acute asthma. Always remember ipratropium bromide with acute asthma, okay, because you have always to give ipratropium bromide. Okay, how do you say this is severe asthma? If the patient tachycardia, tachypneic actually poor guide to severity. Yes, so you have to look for more tachycardia and a recession. Yes, just recession and tachycardia. They're better guide for severity. But tachypneic, you can say tachypneic only if he has 50, more than 50 breath to 20. Yes, you can read this one. And use of accessory muscle with chest recession. Pulsus paradoxes, where the patient difference between the systolic pressure on expiration and inspiration is different. Shortness of breath interfere with talking. So when you are talking to that child, he cannot talk if he's like he cannot talk because of his breathlessness. So this is very severe asthma, and usually you're not gonna see it in the ward because he's not gonna be left this severe asthma. Cyanosis, fatigue, and drowsy are symptoms of life-threatening asthma. This is not something you can joke about. Maybe silent also on chest auscultation. You cannot hear the the airflow in the lungs, because the lungs are already hyperinflated of air. There's no more space to inhale. So that's why silent chest during auscultation. Um, and of course, despite of all this physical exam, you might underestimate asthma. You might say you did not see the cyanosis, you did not count the tachypnea, the tachycardia, you were so busy to notice that he has chest recession, or to notice his pulses paradoxes. So it might you might underestimate asthma. So you have must do arterial and oximeter, arterial oxygen saturation and oximeter. Whether it's lower than 29 or 29%, it's a life-threatening asthma. Okay, some revision for stages of clubbing. You can see clubbing in asthma and cyanosis. Clubbing, stage 1, just normal appearance, a bit curved one. Stage 2, where you lose the angle of just lose the angle, sorry. And stage 3, where you can clearly see the curvature. Stage 4, expansion of terminal phalanx, drum skin appearance. And then cyanosis, you have two types, central and peripheral. Just to make sure you understand, the central is from the heart and the lungs. Peripheral, if the patient is in shock, vasoconstriction, cold exposure, just simple as that. Okay, how do you know it's peripheral or central? If there's the tongue is pink and the hands are blue, this is peripheral and localized. Like, it's only on his extremity. You don't have to worry about the heart and the lungs. But if he has blue tongue and warm hands, like it's not cold, this is central. You have to look for something wrong in the heart and the lungs. And that's it for me. Hope it's made sense, and this you can easily read it and understand. Thank you for listening.